Hi everyone, welcome to our webinar tonight with med school tutors. We are very excited to be talking to you tonight about some high yield EKG findings, how to interpret them, and more importantly, what you need to know to crush your boards in terms of EKGs. My name is Justine Falcone. I'm a current PGY3 resident in emergency medicine, and I've been a senior tutor and residency consultant for MSc for several years. I'm excited to be working here with Sana tonight. Sana, do you want to introduce yourself?
Of course. Thanks, Justine. My name is Sana. I am an intern. I am first year fresh out of medical school. I also have been with med school tutors for a couple of years now since I took step one myself 2.5 years ago now. And we're both really excited to sort of get started on the EKGs and the best preparation for the EKGs that are specifically really high yield for step one.
And with that, let's get started, Sana.
All right. So in order to really think about EKGs, one of the most important things you have to think about is the physiology of what's taking place in the heart. And so the key components here are the electrical system. And so we wanted to give you guys some background about conduction in the context of what's happening in your EKGs. So this is, I'm sure for many of you, a very familiar picture. I believe it's straight out of one of the first aid pages. And so the big things to really keep in mind here are what's happening at an electrical level and also what's happening at a mechanical level within the heart. So if you trace along this top image, so the top image is looking at the LV pressure and the LA pressures, you can see the classic mitral valve closure, increase in pressure, and then that aortic valve opening, which is characteristic of systole. And so as you're looking through this diagram, I want you to always correspond each individual component with what's happening at the EKG in the bottom. So as you can see, the initiation of systole happens with the closure of that mitral valve, and that's where that QRS complex is formed. So systole initiates with the beginning of that QRS complex. However, what's important to note is that systole continues until well beyond the QRS complex no longer being polarized. So that ejection is far more lasting than that electrical current that lasts through. And then even the T wave, which generally is known to be considered QRS repolarization, that's still happening during systole. And so the QRS of the entire left ventricle is repolarizing, re-equilibrating to its normal electrical baseline threshold while the systole is still taking place. And then at the end of systole, we transition to diastole, of course. Now the atrium or the ventricles are filling again. And that's usually when you have somewhere right around the end of the T wave, that's where that initiates, and that will continue until, again, the next QRS complex. And so really keeping in mind, P waves are all about atrial depolarization, right? So nothing is happening in terms of function pumping. At that point, it's all just electrical buildup. And then once the ventricles start to depolarize, which is the QRS complex, that's as soon as we enter systole, and that's when the pump function begins. So really trying to parse out what point is happening electrically and when the mechanical things start to occur as well.
All right, thanks, Sana. Okay, so then let's talk a little bit more about how to actually read an EKG. You'll see all these shapes and amplitudes, and it can be very confusing and overwhelming when you're just staring straight at an EKG if you're not having a great rhythm or way that you go about interpreting an EKG. In fact, I actually always recommend students or anyone that's learning to read an EKG to have a method that you always apply anytime you're looking at an EKG. That way you'll remember exactly what you need to look at, and you'll kind of follow each EKG simultaneously so that you don't ever miss something important, like you don't forget to check the axis or the intervals, which all those little pieces can be key to making sure you identify all the important aspects of reading an EKG. So one of the best steps to reading an EKG, and which is actually what I personally do when I'm working clinically as well, is I ask myself rate, rhythm, axis, intervals, and morphologies. And we'll be able to talk a little bit more exactly about what that means. But the first thing I'll ask is, what's the rate? And we're going to get practice with doing this a little bit coming up as well. But generally speaking, is it tachycardic? Is it bradycardic? Is the rate in the normal range? About 60 to 100 would be normal. What kind of rate are we dealing with? And that's where we kind of start. And the second step would be to ask yourself about the rhythm. And obviously, probably the biggest question overall is the sinus rhythm or not? And we're going to go and talk a little bit more about what that means as well, but there's a variety of different rhythms, and that's something that you will always want to ask yourself when you're interpreting these EKGs. The third step is to say, what's the axis? And is it a normal axis? Is there a left axis deviation? Is there a right axis deviation? Those are actually very important questions because they can lead you to interpreting EKG differently. For example, if there's left ventricular hypertrophy, if there's acute right heart strain, the axis may be different. And so that is why it's always very important to check the axis and see if it's normal or if it's altered at all. The fourth most important step is checking intervals. And in particular, the PR interval, the QRS, and the QTC or the QT interval are probably the most important things to pay attention to. In particular, if a QRS is very wide, that can lead you down a different path than if the QRS is narrow, especially if we're talking about ventricular tachycardias, for example. In addition, the PR interval is important because if the PR interval is abnormally short, that could signify that there's a potential pathology going on, such as WPW. And lastly, the QTC or QT interval is also very important to check because there are a multitude of syndromes and drugs, medications that can cause a QT to be long or short. And there are risk factors on both of those situations. And so it's always important to know what the QTC interval is, especially if you're going to be giving a patient a medication that can potentially prolong it even more. And lastly is the morphology. And so that's basically taking a look at the QRS complexes themselves and seeing what things look like. Does it look like a normal QRS? Is there abnormal areas of the QRS where it's particularly wide? Are the QRS complexes similar in appearance, or do they have different morphologies where they change appearances? You can actually look at the morphology of different parts of the EKG as well. For example, the P waves. Are the P waves positive, upright? Are they biphasic? Do they have different morphologies? That's something that's important to pay attention to. And then lastly, is there an alteration in morphology that you would see with ST elevation, for example? Is this person having a STEMI? And so it's very important to kind of look up, look down, look all around the EKG to see if the morphology appears appropriate in every section. Okay, so let's start and talk a little bit about rate. So that's the first step that we had kind of said is very important to interpret on an EKG. So if you glance at this EKG and we start looking through it, you might notice that something seems a little bit odd. So generally speaking, when a rate or when a rhythm of an EKG is normal, you'll notice that the RR intervals are evenly spaced, tracking all the way throughout. Let's look, for example, there's a lot of different places where you can check, but let's take a look at this V5 rhythm strip way down here at the bottom. If you notice, the RR interval between the first two QRSs is fairly long, but then now it's short again. And now it's a little longer and a little shorter and a little longer. It's changing a lot. And so this will make it very difficult to interpret the rate because it's not regular. So this EKG here is actually showing an example of AFib because we don't really see clear P waves and it's irregularly irregular. And so interpreting the rate on an EKG like this would be very difficult because the RR intervals are not constant. So you may have remember learning in medical school when you're interpreting an EKG about the 300, 150, 100, 75, 60, 50 rule. That is an awesome rule that I actually use the vast majority of the time myself in clinical practice to get a good estimate of what's going on. But in situations like this, where the rhythm's irregular, it kind of fails. And so there are other times when it's trickier to interpret the rate. And honestly, it's probably a little bit outside the scope of what you need to know for the step exam on how you're going to change this. But basically, on certain EKGs, this one doesn't actually have it, but a lot of EKGs will have tick marks on the top of them. And the distance between two tick marks is 3 seconds, or between 3 tick marks, or having 2 essentially, would be 6 seconds. And you can actually count the number of RR complexes that go between them and multiply by 10. and that will kind of give you an average of what the rate is. A little confusing again, because we don't see the tick marks on this particular one, but an actual EKG that you would have in front of you would have that. Or if for some reason we're going to test you that, obviously that would be there. But that's another way that you can go about doing it, is to actually just count how many RR complexes or QRS complexes come between those two tick marks, which will be 6 seconds, and then multiply by 10, that'll give you an average. So that's another way to do it, which is actually probably the best way to check in a situation like this when you have AFib. But for the vast majority of situations, the 300, 150, 100, so on rule works really great. And honestly, if you're going to be tested on it for the purposes of the step and they were actually going to ask you the rates, that would probably be what was going to be used the vast majority of the time. So those are kind of just some key areas to think about when you're considering the rate.
Awesome. So the next thing that Justine mentioned, that when you're doing your systematic approach to going through EKGs, the next thing that I look at, and I think that most people tend to look at, is the rhythm. And so rhythm can be really challenging, because sometimes when you're on the wards and when you're working with clinicians who have looked at a ton of EKGs, they can pick out the rhythm just like that. And you're like, wait, I don't know how you necessarily came to that conclusion. And so I think it's really important to have a systematic approach just to doing the rhythm itself. And so the first thing that I'm sure all of you have heard in every EKG lecture is look for the P's and the QRSs. And that really does stand true. So what I really try to identify is look for anything that could be a P wave. And so don't necessarily look right in front of the QRSs, because that's where it's supposed to be. But certainly if you're getting EKGs, a lot of the hospitalized patients, that's not where it'll be. But you need to have P before every QRS and QRS after every P for it to be sinus rhythm. And what sinus rhythm means is that it's coming from the SA node, right? That's what that means. The SA node is dictating where all of the depolarization happens and when the QRS complex depolarizes as well. And so that is P before every QRS, QRS after every P. And the other things that are important in that is looking for a T wave after every QRS as well, because again, you need to see that repolarization occur in addition. I will say that for the purposes of step 1, there are a few particular EKGs to know more than others, which we will again get to later. So certainly there are situations where you need to know like AVNRT, AVRT, all of these very specialized EKGs. And those are a lot of the time, unfortunately, the best answer I can give is just pattern recognition. It will be looking at those EKGs over and over again and identifying where those Ps are, where they're coming in relation to the QRSs, and establishing those relationships. Those are not the ones you'll need to know for step 1. The ones you need to know for step 1, we will get into in detail a little bit later, but the big things for you guys to be aware of as you're generally approaching EKGs is to start to march out all the Ps, march out all the QRSs, and see where they land in relation to each other. And that'll give you a framework moving forward once you have all of those diagnoses off the top of your head, which you will. With time, you will know all of them and what they come with. And a lot of that is just practice and memorization, as I said. But starting to have that framework of always looking for the P's and QRSs is how you really start to get there, I feel. Anything else you have about rhythm, Justine?
Yeah, I pretty much agree. That was excellent, Hannah. Yeah, and for the purposes of step, they're not going to give you like a very complex rhythm that would be extremely hard to identify, or one in real life where like, this doesn't really make sense. Like, is this sinus rhythm or is this a ventricular rhythm where I'm not seeing a lot of P waves? They're not going to give you something super tricky like that on step. The big things for the rhythm is going to be, is it sinus or not? And if it's not sinus, it's probably going to be something else like flutter or fib. Those are like the big things. And then of course we'll talk about some heart blocks and things like that. Those are really the big things that you would expect to see on step. Yeah. Okay. So then access. Access was something that always confused me as a medical student, and I saw this picture, and at first you're like, whoa, this is really weird, but actually if you break this picture down in your mind, it really helps me when I'm looking at the EKG, because I almost picture this and where the access would fall, and then it reminds me. And so the really important thing here to note is this green section where you notice -30 and 90. And so that is the area which would be depicting a normal axis. And that's where it would fall between there. And so really the key things you need to know about this diagram are leads one and AVF. Those are the two areas on the EKG where you're going to be looking at to see if you have a normal axis or not. In some situations, if they're flatter or it's a little bit difficult to tell, you can go to lead 2 as a tiebreaker. But really, 1 and AVF in the vast majority of cases, especially for the purposes of a step exam, are really going to be all you have to look for. And the big key part of this diagram here is imagine the AVF and the lead 1 as vectors. And you see the arrowheads pointing in a certain direction. So that's the positive direction of the vector. And so the lead 1 is pointing to the right of the screen. And so imagine a line coming all the way from the left, an arrow essentially, from all the way from the left of the screen, pointing towards the right of the screen, exactly horizontally in the direction of lead 1. So that would be the positive direction. Then look at AVF and imagine a perfectly vertical perpendicular vector to the lead 1 with its arrow pointing all the way down to the bottom of the screen. That's AVF. And so if you picture an EKG, and we'll get some practice with this on the next slide as well, but if you picture an EKG, leads 1 and lead AVF, if they are both upwards, meaning the majority of the QRS complex is in a positive upward direction, then both of those are upward, then that would be signifying a normal axis. Now, what happens if lead AVF is upward, but then lead 1 is mostly negative deflected? Well, if there is, like, for example, it's all kind of below the normal horizontal, meaning it's a negative deflection, in that case, lead 1, let's look at our diagram here. Well, that means the vector would actually be pointing in the opposite direction. So instead of being pointed towards the horizontal vector here being pointed towards the right of the screen, lead 1 would be pointing towards the left of the screen. And if we look at our diagram here, where does that put us? Well, that puts us in the right axis deviation area. And so generally, if it's a more negative vector of the QRS complex in lead 1, generally speaking, that leads right axis deviation. It can get quite complicated with the extreme axis and all of that, but for the purposes of step 1, if AVF is positive and lead 1 is negative, it would be right axis deviation. On the other hand, if we look here at AVF, let's say that lead 1 is positive, pointing upward, but lead AVF has a more negative deflection. Well, then the vertical vector that we see here would be pointing in the other direction, meaning it would be pointing more upwards into the left axis deviation range. And so that would mean that you would have a left axis deviation picture. So to summarize, a normal axis on an EKG is going to be a positive, mostly positive deflected QRS in leads 1 and a mostly positive deflected axis in leads AVF. If you have right axis deviation, lead 1 would have more of a normal negative deflection. If you're having a left axis deviation, leads AVF would be having a more of a negative deviation. And so those are kind of the basics to explaining axis here. But let's take a look at an EKG because that'll actually make it a little bit more sense. But I think we're first going to talk about intervals first, Anna, and then we'll get to axis, our slide over here. Let's talk about intervals, and then we'll discuss the axis a little more on the EKG. But really briefly here, this is what I'm talking about, lead 1 and leads AVF, positive QRS, it's a normal axis. Okay, go ahead, Sana.
No worries. That was great. So the next thing that we sort of go through, so we went through rate, rhythm, axis, now we're at intervals. And so there are a number of intervals to look for on every single EKG. There are a few that you need to know for step 1. So the number one most important thing I can teach you now is what these different boxes mean in terms of timing. And Justine already did a great job of describing that when we were going through the rate slide, but just to sort of reinforce it, these heavy black lines you see, the heavy ones, the big boxes, each large box is 0.2 seconds, right? So that's important to know. The entirety of a large box is 0.2. And then each of the small boxes, there are 5 small boxes within each large box. So naturally 0.2 divided by 5. So each of those ends up being 0.04. And so that sort of should be your framework for how you're figuring out what's long, what's short, what's a normal interval for all of these things. So the first thing that's important is determining in a lot of the heart blocks. And so this is where this becomes clinically relevant, right? So the PR interval is going to be crucial in the heart blocks. So the normal PR interval is between 120 to 200 milliseconds. And so you will look at and so really the upper cutoff that you just need to know is that 200 milliseconds. And so really just looking for those boxes and seeing, do we go over that? And that's a normal PR. So PR are 200 milliseconds. That's what you're looking for your cutoff. The other one that's important to look for is a QT. It won't be super relevant on step one. No one's going to ask you to calculate what the QT is on step one. But it's important in terms of identifying, because they might say, this is the person's EKG. Can I start them on some QT prolonging medication, right? Like, what is an appropriate therapy to start? And what you're supposed to be looking for is, okay, how's their QT look? Is it an appropriate, like, can I start them on azithromycin? Is that okay? And so the QT is from the beginning of the QRS complex to the end of the T wave. And so it's not from the beginning to the beginning, it's from the beginning of one to the end of the other. And so normally on step one questions, they're going to be grossly prolonged if they're going to be asking you a question about them, but the normal should be typically less than 420 milliseconds. And again, you should be using all of those same rules that we were talking about. Large box is 0.2, small box is 0.04. And so QT, really what they're not going to ask you to calculate it. They just want you to see, is this too long? And then the PR 0.2, that one I would make sure you just see, is this long? Is this heart block, etc. And that'll be your sort of idea. Another thing that's important for you to know broadly, especially as you're going into third year, fourth year into the residency, QRS is normally less than 120 milliseconds. However, you'll never be asked to do this for step one, but just good for you to know in terms of a wide complex tachycardia versus a narrow complex tachycardia. You'll learn all about that when you do ACLS training. But that's another sort of criteria that you should be thinking about when you're looking at broader intervals.
Yeah, awesome. Another great trick that I use actually in clinical practice for just a rough estimate if the QTC is prolonged or not is that you actually look at the RR intervals, and if the T wave ends halfway between the two intervals, generally speaking, it's probably not super prolonged. But if we look here for example, like in the bottom screen here, we actually can split maybe the RR intervals in half. I would say it probably ends about here. If you notice that the T wave hasn't actually completely finished there, so it's probably just a rough estimate. Maybe it's a little bit prolonged. Again, that's not going to give you a number, but if you're just looking at EKGs really quickly, or you're running out of time on step, and for example, they want you to like notice that the QTC is long, that could be a quick and dirty trick to just say, "Ooh, I think that's long. I don't have time to calculate it, but I think that's long." That's something I like in clinical practice too. But yeah,
absolutely. And so if we look at the next slide, we can actually see when they actually do that exact halfway trick. You see that the T waves have not quite yet finished. So this is an example of a long QT because they aren't quite done yet. And so really holding that as like the T wave has to be totally done. We have to be on the flat line now, really using that as your threshold.
Okay, so then morphology. Well, if you take a look at this one, you might notice that something looks a little bit off. And so again, there's a lot of different areas that you look at for morphology. But take a look at this EKG, everyone. Let's look at our rate, let's look at our rhythm. We can take a quick peek at the intervals, and then look if there's anything different that we notice about the morphology. There's something striking that you could see here, and this is a very classic EKG that they would present on a step exam that you need to know. So if anyone has any ideas, you can just start kind of putting chat ideas of what you think might be going on. You can be very broad and say this is happening, or you can be a little more specific and identify exactly where the morphology is. And I see some answers already coming in. Yeah, ST elevation, exactly. So this person could be having an acute heart attack, a STEMI. Oh, good. Someone was even more. Yeah, great. And 2-3 in AVF. Oh, wow. Someone got even fancier. They noticed the posterior component. Good. I'm going to talk about that. So yeah, the classic is the 2-3 in AVF. Is that ST elevation there, and you see reciprocal changes in leads 1 in AVL, which is mirroring this inferior MI. So that's great. Now, someone else was very astute, which I think is probably beyond what they would test you on step, but they actually noticed that there's posterior extension as well, which I agree with, because you see slight ST depressions over here in these leads V1 through V3, and those slight ST depressions could be signifying that there's a posterior MI. So if you just saw this, you could get posterior leads and see if that's actually the case. but that's a little bit of outside the scope of what they'd actually test you on the step. But what they really want you to get here is, yeah, there's an inferior extension. And one of the classic things that they like to test on is, you know, does anyone know what medication, if you saw this patient with an EKG and they're having chest pain, what's the classic medication you would want to avoid and not give a patient with an EKG like this? If anyone has an idea, throw it in there. That might be something else that they would do. Yeah, people are already saying them, right? Excellent. Because good, nitro, yeah. So people with inferior, actually, really in reality, it's when they have posterior involvement as well. That is the big concern, is that when there's a inferior posterior type STEMI, you are very preload dependent in your heart. And so you actually need fluids. You need to be able to pump well. So in those people, you do not want to drop the preload by giving them nitro. Pretty much in any other STEMI, most other STEMIs, it's actually great because it'll give them a little vasodilation, their coronaries will perfuse a little better, and it will relieve their chest pain and they'll feel better. But in patients like this that are preload dependent, actually giving them a small bolus of fluids is much, much better. They may be hypotensive already, but if they're not, giving their heart a little preload will help their squeeze more. Something like nitro will tank their blood pressures and worsen their cardiac output. And so this is the classic type of picture where if they ask you, you know, what type of medicine not to give a patient, nitrates or nitro, it is not something that you would want to give. Nitroglycerin, sorry for being using the term. Nitroglycerin is not what you want to give this patient for their chest pain. And so that may be something that's pertinent. But this is a really striking example of morphology. And so, yeah, this person has a STEMI. They need to go to the cath lab, have an intervention, or get lytics if there's not cath lab available at that facility. But this is a classic example of an obvious MI that we see here with the ST elevations, the reciprocal depressions, and a little posterior extension that you may be responsible for seeing on the exam. Okay. And let's see what we have here. Okay, so inferior MI, I'm trying to get that one away. Okay.
Perfect. So now we're starting to think about now that we've gone through all of the different steps, sort of what our differential is when we see a patient who comes in with some sort of tachyarrhythmia. And so when you have a patient with tachycardia, you're getting the EKG sort of to narrow down your differential and give you a couple of branch points. So the first branch point is something that we were alluding to when we were talking about the intervals. And so that would be a wide complex tachycardia or a narrow complex tachycardia. And as we said, the normal QRS is 120 milliseconds. And as we said, one of the small boxes is 0.04. So 3 of those is the cutoff. 3 small boxes should be your cutoff for narrow complex versus wide complex tachycardia. And there are sort of 4 branches. So let's say that we have a narrow complex tachycardia, right? Within that, you can have a regular rhythm or an irregular rhythm. And so again, what did we say for rhythm? Rhythm is all about P before QRS, QRS before every P, or after every P, and making sure that you have T waves following all of those as well. So if we have all of those criteria, that leaves us with a few options. One of them is just sinus tachycardia. So that really means look for something else. It's probably not something cardiac. Look for some other process that's driving this. Another would be a supraventricular tachycardia. In those cases, sometimes we don't see P waves. So be aware, and that's another sort of branch point in that differential. And then atrial flutter. So the caveat here is that you don't have a QRS after every P. There's a regular interval, and you do have a P before the QRSs, but you should be able to see that something like atrial flutter, you have some sort of ratio between the Ps and QRSs. Then there's a question of irregular rhythm. So irregular rhythm has to do with more lacking that PQRS association. So that would be AFib, right? AFib, you can see some P waves, you might not see P waves, they're sort of all over the place, but there seems to be an irregular RR interval, and that varies every time. And then you have multifocal atrial tachycardia, which again, you're seeing P waves sort of from all over the place. They look different in morphology. They're variable in terms of their spacing relative to the QRS. So that is another tachycardia. And you can also have that in the same form, not as a tachycardia, in which case it's called wandering atrial pacemaker, right? So something else to keep in mind for that if you have P waves that look different every time. And then again, irregular, A flutter with variable conduction, right? So A flutter normally has a strict 2-to-1, 3-to-1 ratio, but sometimes you'll have sort of incomplete penetrance of the conduction system. And so then you won't have that same ratio every single time. It won't be a regular rhythm. So that's sort of our narrow differential. Then we're looking at wide complex tachycardias, and these tend to be more ventricular mediated processes. And so if it's regular, you're thinking about ventricular tachycardia, the ventricles are just going by themselves. Sinus tachycardia with aberrancy can also do this. And then SVTs with a bundle block, that can lead to a wide complex because there's delayed conduction, or a Wolff-Parkinson's-White picture as well. And then if it's irregular, again, AFib with bundle block, AFib with pre-excitation, and ventricular fib. I will say, this is all a lot, and this is all a lot of data and a bunch of different diagnoses for you to think about. Most of these will not be tested on step 1. So again, definitely, I encourage you to read about them. I encourage you to try and learn more about how to identify these different patterns. But the ones that you really need to know in terms of the tachyarrhythmias, we're getting to, but really what I'll say, sinus tach, AFib, A flutter, VTach, VFib, and then Wolff-Parkinson-White. Those are really the big ones that you should focus most of your energy on for the exam, but the rest of them will come up in real life. So they're important to know, but maybe not as immediately pressing as the exam ones. Okay. All right, and so thinking about what we were just talking about in terms of wide and narrow complex tachycardia. So let's start with this top EKG we have here. So patient history, and again, patient history is key for all of these. Patient that's overdosed on tricyclic antidepressants. Is there anything that jumps out about this EKG, anything that you guys are thinking about in terms of what the diagnosis might be? Great. Already starting to see a couple of them come in. Perfect. So the big thing here to keep in mind is this narrow or is this wide as your first point? And so you can see this is just a complete sort of wide open, just sinusoidal pattern. And it's changing in terms of sometimes it's low amplitude, sometimes it's high amplitude. It's sort of going back and forth. And so that coupled with this history of tricyclic antidepressants. So those are medications that are famously known for being able to prolong the QTC, right? And prolonging QTC predisposes you for this condition. So as a lot of people have said, polymorphic VTach, otherwise known as torsades, right? So that's what's happening to this patient. So again, history is really key because you know, okay, TCAs, QTC, it's probably going to be something to do with that. And then also just looking at this alone, sinusoidal pattern, wide complex, you can get there both ways. And sort of if you have both of them together, it really helps you anchor down on that diagnosis. So that's the first one. And then the second pattern is a patient who comes in after MI a few days ago. So again, throw out your answers. What are you thinking in regards to what might be happening to this patient in their actual diagnosis? So something to be aware of for this patient is that we have, again, it looks like a wider complex because you're still seeing something a little bit more sinusoidal, but you're not seeing that same amount of amplitude. And I think that's really important to hone in on. You're not seeing that same amplitude and you're not seeing as much of a defined movement. This looks a little bit more like something's just like puttering along. And it's a difficult distinction to make, absolutely. But what I really try to look at is if you look at AVR, that's the lead that I'm really looking at. That just looks like it's puttering. That doesn't look like any sort of distinguishable activity. It just looks like it's sort of like fibrillating, one might say. So when you look at this one, and I think about the history of having an MI, which is not necessarily specific because having an MI a few days ago can predispose you to a number of arrhythmias. But that coupled with this sort of small, low amplitude pattern makes me think of ventricular fibrillation. So this is emergency, needs urgent, well, I mean, they're both emergencies, but this immediately sort of raises my red flags, both of these EKGs for a very, very dangerous process. Great.
And yep, here's our answer. So just so we can see them again. Okay. So a little practice here. What do you all see going on here? Let's say in terms of maybe the rhythm. Anything strike you as normal, abnormal for the rhythm? We don't have to get too crazy in identifying every aspect of intervals and everything like that, but what any sort of rhythm abnormalities, and then in particular, there's a few leads that you see them better. So I see some answers already coming in. A lot of people are saying, yeah, someone said sawtooth, which is great. That's a key thing to look for. And the sawtooth is synonymous for atrial flutter. So yeah, A flutter is kind of what we're seeing along here. I see a lot of people giving those answers. And in particular, we're seeing A flutter with a 4-to-1 block. And so we had talked about before how there could be a 2-to-1, 3-to-1. It could be more irregular, 4-to-1. In this case, you're really, if you will honestly look in leads 2, 3, AVF, maybe AVL, maybe AVR is where we see it the best. If you look in some of the other leads, it's a little bit more confusing because you don't see it quite as well, but you really see that classic sawtooth pattern in leads 2, 3, and AVF. And this one's a little bit trickier because you might say, well, I see like 3 P areas between these, so isn't this 3-to-1? But it's actually most likely one of the P's is buried in some of the QR complexes just because it's going so fast. The reason you can kind of notify that, especially in lead 3, is some of the QRS morphologies look slightly different, so more than likely there are some P's buried in there. So this is probably more of a 4-to-1 block type of picture. I see some people were questioning whether it was 3-to-1 or 4-to-1. And then in terms of ST depression, I know some people also saw that, maybe pick that out. Maybe there's a little bit in V1. I could kind of agree there. I noticed someone said that, but I don't really see any reciprocal elevations anywhere. I don't think I see in any of these other leads any depressions. This is just kind of a classic example of atrial flutter. And so really, if this was on your board exams, that would be what they'd want you to see. Not really a ton of the other little intricacies, but more that there's this classic sawtooth appearance. And that's really what you should remember when you're thinking about atrial flutter.
Awesome. Okay. So another one here. So there are a couple of things. So I'll let you guys take a second, look through this, see if anything jumps out at you, if you want to throw your preliminary diagnoses in, and I'll sort of walk through what I'm looking at when I see this. So we have very helpful red arrows here to sort of direct us to what we should be looking at. One thing that jumps out to me is this first red arrow, where you see a very, very short PR interval. So one of the intervals we were talking about before was that PR segment, which should be upper limit 200, lower limit 120. And these are very, very narrow PRs. And in addition to that narrow PR, you see something that we call a delta wave. And a lot of people are appropriately identifying that. Great sort of point here is that you're seeing that delta wave with a slow uptick in that QRS. So it doesn't go straight up. You see a little bit of like curvature before the QRS complex begins. And that's sort of pathognomonic for one specific diagnosis, which we will get to. You also see a slightly longer QRS because of that longer initiation of that delta wave a little bit earlier. It's not super long. It's not longer than that 120 cutoff that we talked about, but it is a little bit on the longer side. And so again, that delta wave, that shorter PR, both of those things all together makes us think of Wolff-Parkinson-White syndrome. And so this is, again, one of those EKGs that they will absolutely be, you should expect to see this on step 1 or on your practice exams for step 1. This is a very commonly tested EKG. And one of the things to sort of know is that what is happening here is that you have an accessory pathway that's just bypassing the AV node. So you're having the complete just AV node is not involved, and you're going through typically the bundle of Kent, which is just an accessory pathway that's moving around that. So for that reason, there are some medications that are very much contraindicated in patients who you might suspect have Wolff-Parkinson-White syndrome. Anyone have any ideas about what those medications might be, what you might want to avoid in people who are already bypassing the AV node? Great, already seeing some good answers here. So the big thing is, as I sort of alluded to, the AV node is already sort of being worked around. So any medications that are nodal blockade providing medications would be contraindicated in these patients. So that's beta blockers, that's calcium channel blockers, adenosine, amiodarone. A lot of those medications we want to make sure we avoid because that can precipitate worsening of their Wolff-Parkinson-White, worsening tachycardia. So we want to make sure we avoid that. So the big things again that I'm looking for: delta wave, that slight increase, that slight shortening of the PR segment, and then sometimes a slightly longer QRS.
Awesome. And let's go. So WPW, yep.
Yeah.
Okay. So then now we talked a lot about the fast stuff, or kind of where we need to worry about for the fast stuff. I want to talk a little bit about the slow things you have to worry about. When someone's heart rhythm is slow, what sort of differentials come into mind? And so the big ones are here on the screen, and these are the ones that they are going to test you on for the purposes of the STEP exam. And we're going to kind of break it down, and you'll see lots of examples of these as well. But there's several different types of blocks, as you learned about in medical school. The first type is a first-degree AV block. And really what that means is that the PR interval is going to be slightly prolonged over that 0.2 seconds or 200 milliseconds. It'll just be a little bit long. But what you'll notice on the EKG is that it's constant and stable throughout. Every single part of the EKG, every PR interval before every QRS is going to be that slightly prolonged, constant, stable length. The interval is not going to be changing. You're not going to see any dropped beats where there's just a P hanging out alone without a QRS complex after it. Nothing like that. It's just going to be slightly longer than normal. In the vast, vast, vast majority of cases, this person would be completely asymptomatic because it's not going to significantly affect conduction through the heart. They're not going to usually have palpitations, syncope, dizziness. If that was going on, I would be very suspicious of looking for something else, like they're actually having episodes of, VFib or VTAC that you're just not catching, something like that. So usually this is very benign, asymptomatic, and there's honestly nothing really to do other than just to monitor it. And then when we talk about the second types of heart block, there are the second degrees. And this is broken down into two categories, one that is a little bit more on the benign side and one that's a little bit more on the scarier side. And so there's a Mobitz type 1 and Mobitz type 2. And so how do you distinguish these? Well, they basically vary determined by the PR interval. So a Mobitz 1, the PR interval is going to get longer and a little bit longer and a little bit longer and a little bit longer until, bam, ultimately a QRS complex is dropped and there's just going to be a P wave hanging out by itself. And so this is a little bit more reassuring in that most of the time patients will be asymptomatic. They may have a little palpitations and some symptoms associated with this, but usually this is fairly well benign as well, and doesn't require a lot of immediate treatment. It's just something that you'd want to monitor them very closely to make sure they don't progress to a higher degree block, or give them symptoms if they, what to look for if they become symptomatic. The big thing here is to also make sure you're absolutely certain that it is a type 1 and that it's not a third degree block or a Mobitz 2. And the way I remember Mobitz 1 and Mobitz 2 is that Mobitz 1 gives you a warning, and you can almost hear the word 1 in warning if you say it right. So Mobitz 1 gives you a warning that something's going to happen and there's going to be a QRS that's dropped because it gets longer and longer and longer. So that's your warning cue that something's going to happen. So I kind of like that little trick just to remember the two different types. A Mobitz 2 is more concerning because the QRS are dropped randomly with a PR that is more constant. And so the PR interval is not going to progressively get longer. They would be very constant like in a first degree, but the difference here is that there's going to be a QRS that will get dropped. So you'll see a random P hanging out with a QRS that's not conducted through. And then these patients may be asymptomatic as well, but they often are not. They often have dizziness or palpitations, things like that. And ultimately, these patients will progress to needing a pacemaker because they have a very high likelihood of progressing ultimately to a third degree block, meaning that basically the Ps and the QRSs are not talking with each other at all, which is very concerning. And so this is a more high degree block that generally requires a pacemaker. Now, technically, for any of these blocks, if a patient is coming in symptomatic, bradycardic, you could try atropine on any of these and see if they would work, and it may. Generally speaking, atropine works a little bit better on the lower degree blocks. You're probably not going to see a response in complete heart block, although if a patient is very unstable and you're getting ready to pace them transcutaneously or transvenously at the bedside, having atropine there just to, give it a try in case, it wouldn't necessarily hurt them, but it's probably not going to do anything in a third degree block. Mm. And then for the third degree block, this is where, and we're going to get lots of examples of these to practice later in the webinar, but the third degree block is when the P's and the QRSs are completely disassociated. So you'll see P's randomly marching through on their own all the way through, P, P, P. So those intervals between the P's will be even, but they're not going to be correlating at all with the QRSs. You might see, and this can get a little confusing because you might see a P wave buried in a QRS, it might be buried in a T wave, but if you actually take the time to march out the P's, they're going to be constant kind of throughout. And then the same thing with the QRSs, they're going to be not associated with the P's at all, but they'll be associated with each other. So if you march the QRSs out, they'll be more constant with themselves. So basically it's like the P waves and the QRS complexes are not getting along compatible at all. They're each doing their own thing, not talking with each other. You're not going to expect them to a P to be before every QRS and vice versa. Okay. So let's practice a little. Everyone take a look at this EKG. Kind of type in some answers if you have an idea. Again, this will be more for we're talking about, as you can probably tell already, it's bradycardic, very, very slow rate here. And so see if there's anything, yeah, I see people already saying bradycardia, that's right. Look more specifically, what type of bradycardia? Is it just a sinus bradycardia? Are there any blocks or abnormalities you see going on? I see some people saying sinus. Let's keep something first degree. Okay, there's a little bit of a difference here. This is a tricky one. Lots of different answers coming in.
Got a lot of different options here.
This is very tricky, and this would make this particular type of block hard. I do see someone has it right, though. This is a 3rd degree heart block. And someone did say axis deviation. Yeah, that is actually a true statement. The EF is pointed negative, so good job there. That is more of a left axis type of deviation, so that's true. If we're more specifically looking at what's causing the bradycardia and where that's related to, it's a 3rd degree heart block. And so let me actually pull the next one so we have a little more here. This is a complete disassociation, so it's a little blurry and a little tricky to see. But let's look at the very last rhythm strip, V1, and you notice these little teeny blip, blip, blip between the QRSs. Those are the P waves. And if you count them out from P wave to P wave, now we have another one. Oh, the 3rd P is actually buried in the QRS. That's why it looks a little bit funky compared to some of the other ones. Then we count it out again. Oop, the next P comes after this T wave, and there is no QRS following it, so it has dropped. So we know right away that this can't be a 1st degree heart block, because here and here on this V, in some of these longer stretches, we see P waves that have no QRS conducted after them. So automatically right away, we know it can't be a 1st degree. So we'll take that out of the way. But if you even look at a lot of QRS complexes, they don't even really have a P wave right in front of them. And so that makes it a lot less likely that it's a 2nd degree heart block. In some places you might even look like here, I don't even really see a lot of P waves. So that's what makes it tricky. But the big thing here is that if you count out all your P waves, they're going to be very constantly marching through. Sometimes they'll be buried in a QRS complex. Sometimes they'll be buried in a T wave, which we actually see over here, maybe a little blip where a P is buried in a T wave. And then the same thing, though, if we look at the QRSs, they're going to be marching out independently on their own very constantly. So this is a very classic example of 3rd degree heart block. When I was learning these blocks in medical school, I always remembered being a little bit confused because I was like, well, isn't this maybe this is a Mobitz, 1 or 2 when we're just getting these dropped beats everywhere. So you have to really look high, look low, look everywhere, because the P waves like to hide. And especially in a 3rd degree heart block, it can be a little tricky if you're not recognizing that P waves are buried in QRS complexes or they're buried and merged with a T wave. Really the distinguishing factor here is that they just march out, and you'll see areas like over here where you see an abnormal blip. Maybe this over here has an abnormal blip, this T wave. So those are P waves that are just marching out, and they kind of merge with the complex that they happen to be crashing into. And so keep that in mind when you're working with 3rd degree heart blocks, is that the P's are going to march out on their own regardless of what else is coming. And so look everywhere to find those P's. And then I think someone say, wouldn't this patient be very symptomatic? Yes, this patient will be very symptomatic. You may try atropine, but that's probably not going to work. They're probably going to have a very, very slow heart rate, look ashen, look gray, maybe be hypotensive as well, feel extremely sick, maybe diaphoretic, they probably feel dizzy and weak. And so yes, this patient is very symptomatic. Treat with a pacemaker. I see people say, yep. So this is the patient where you're going to have atropine at the bedside. You're going to take pacer pads and put them on it and probably try to start transcutaneously pacing them. Depending on where your facility is, some patients that might be hard to do, and you would actually have to you know, try to get a transvenous pacer in if they couldn't get a permanent pacer. Other places you can do, you can go right to a permanent pacemaker if you have cardiology there that they may take them. Can we do a heart transplant on these? You probably want to jump right to that yet, just because it's a conduction abnormality. The rest of their heart may be functioning right. So, and these sort of, someone just asked that question. In these sort of patients, you would try to treat with a pacemaker first. Now, obviously, if that didn't work and they progressed to full-blown heart failure, things like that, they ultimately may need a transplant down the road. But right away, the key thing would be transcutaneously pace, put pacer pads on their skin. In some people who are obese or sweaty, it may just not conduct well, and you would have to go more invasively with either a transvenous pacemaker at the bedside or just take them straight to the lab and put a permanent pacer in. But again, those things are a little bit outside the scope of what you'll need to know for step, more identifying it and then realizing that you need to do an immediate intervention to get this patient treated.
Awesome. So now we have another great example. So this, full disclosure, there are two really big things to look for in this EKG. So try and go through all of our basic steps, rate, rhythm axis, all of that, and see what you think of. Just walking through this as I'm looking at it, the first things that I'm noticing is sort of the rate, right? So I'm trying to go through. And so what I immediately see is between the first R and the first QRS, second QRS, third QRS, just from gestalt alone, they look pretty irregular in terms of the distance between them, but they also look very far apart. So this patient is significantly bradycardic. And one person has correctly identified we have sinus bradycardia here because, again, what we're seeing, you're seeing a P before every QRS and you're seeing a QRS after every P. So that in and of itself tells you that you have sinus. The big thing that we really want to look for here is the different, because we're looking at bradycardia, we want to see what are we seeing in terms of the PRs, so, and the P in relationship to the QRS. So what we can see here is that the P and QRS complexes are a little bit further apart. So again, that cutoff that I told you about before is 200 milliseconds, right? 0.2 seconds. And so here we're seeing prolongation of that. That's longer than a box in between them. And so that tells us, okay, we have first degree AV block. So this is sinus bradycardia because the patient is going at a slower rate with P's before every QRSs, but they also have first degree AV block. The reason this is not Mobitz 1 is because Mobitz 1, again, you would see lengthening, 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 and then a random drop. And so those things have a gradual lengthening versus here, we're seeing pretty consistent intervals in front of all of them. However, then Mobitz 2 would be like the random drops. But again, we're seeing pretty consistent PR intervals in front of all of these complexes. So the diagnosis here, sinus bradycardia and first degree AV block, as a lot of you have accurately said.
Awesome. And I think I saw someone comments like a little confusion here in V1. If you notice, it looks like there's a little gap here. And when I get EKGs in real life, sometimes get confused if I see something like this. And that might trick you to think that it's a Mobitz because you're like, oh, there's a space where there's not a QRS. They must have a dropped beat. But they don't because there's no P wave here at all. You notice that the P waves are really constant in front of their QRSs. There's not a random P hanging out alone. So this is more likely this makes this EKG a little trickier. If you look at all the other leads, it's not an issue, but this one little part here, there's this QRS that's like, what's happening? It comes a little bit early. I think this is just a premature beat. You can also get a sinus arrhythmia that looks like this, especially in younger people with breathing pattern variations. In those cases, there's still a very classic P before every QRS. This may be a PAC because I don't even see a super clear P before it, which is a little tricky and again, kind of outside the scope of this. But if you look at basically, if you ignore this, all the rest of them have a very clear P before the QRS. It's not a Mobitz type pattern because there's no dropped beats really.
Perfect.
Okay. And so yeah, perfect. I think this is just where we talked about it a little more. Mm-hmm. And then wrapping up. Okay, guys, so get ready to fire your answers because we're going to go through some rhythm strips and we're going to throw them up on the board and you can kind of see them.
All right, so first one, take a look, see what you see here. Try and go through, again, you're not going to be able to do it as systematically because this is sort of, these are rhythm strips, so more of a like gut reaction, what's jumping out at you. First thing I see, it's definitely going fast, right? There's a pretty short interval between all of them. And then again, I'm thinking in terms of my tachycardia branch point, narrow complex, wide complex. So I'm thinking, okay, these all look pretty narrow. They're less than 120 milliseconds. Am I seeing P's before every QRS? Am I seeing QRS before, after every P? And I think I am. The T waves are so close to the P's that they sort of make this weird shape. So it's a little bit confusing as to what you're seeing there. But I think all of these little like divots where you see a little bit of almost an M formation, that's just the end of that T wave superimposed almost on that next P wave. So what we're seeing here is just sinus tachycardia. So it's going so fast that that P wave is getting moved up. But again, you're seeing P and QRS 1-to-1 ratio, appropriate intervals in between them. So this is just sinus tach.
Awesome. All right, guys, a little bit trickier here. What do you think's going on here? Kind of good look at some of your intervals.
Got some great ones already.
Yeah, people are already describing what you see is always great too. So that's awesome. I see some people saying irregular rhythm. That is absolutely right. Irregularly irregular, to be more specific.
Perfect.
Yeah, I see a lot of people kind of shouting some of those out. Someone said ST elevation. I don't think I really see too much ST elevation. The baseline's wandering a little bit, so that sometimes makes it a little trickier. Like over here, how we have a little bit of a change in the baseline, but really there's not too much ST elevation if you compare the TP segments here. So I wouldn't call any ST elevation. And really it's the fact that in order to have lots of ranges, this is really a classic AFib. It's irregularly irregular. You're seeing some like artifacts here when you see these little blips, but there really aren't any classic P waves before the QRSs. You see that the RR intervals are abnormal spaced. They're changing a lot. This is a very classic AFib type of rhythm trip, which you should be aware of for the purposes of the step.
Absolutely. Nice. Okay. So now we have a slightly different one. So again, just looking at this, I see a whole strip. I only see a couple of beats. So that is already making me go down a certain algorithm in my head. Feel free to throw out as you're thinking what might be going on. But again, as I already said, we're going slow. So this is some type of bradycardia. And then as soon as you think bradycardia, I want you to think, okay, there's sinus brady, and then there's all of the heart blocks. That's really all you should be thinking about for the purposes of step one. That is your differential. And then once you have that, it's just a matter of, okay, are we having drop beats? Are we having a long PR? What are we looking at? So here, when I'm looking at this, I see if you look at the second QRS complex, you see a P very, very soon before that QRS complex. So I'm like, okay, that one's pretty close. And then I look at the next one and I'm like, oh, there's nothing there. And then I see the next P, still nothing there. Then I see the third P. There's a QRS very close after that one as well. Then I see a P, then I see a long gap, and then I see another QRS complex. So what I'm seeing here is that there is some degree of association between the P's and the QRSs. When I'm marching out the P's, they're not going at a steady interval completely separate from the QRSs, right? So when I'm thinking about third degree block, the P to P should be the same and the R to R should be the same. R to R is not the same here, right? We have a short interval, then we have a super long interval, then we have a medium, then we have a short again. So that's out. So it's not third degree block. Then there's first degree block, which is just a consistent P to QRS, P to QRS. That's out because we see some P's without QRSs. So now we're in second degree. And now it's really a question of, is it Mobitz 1 or is it Mobitz 2? And when we look at this, I can't really make out a clear pattern here. It's not getting longer and longer and longer and dropping. It'll be 1 then drop, then 3 then drop, and then you're seeing a very inconsistent sort of pattern here. So when I look at this, I see, okay, this is Mobitz type 2 bradycardia because of the fact that you're not having regular intervals and regular dropping.
Awesome.
All right.
All right, guys, take a look at this one. What do you think might be going on here? See a few different answers coming in right now. The big thing is, let's see, is it narrow or is it wide? Well, it looks pretty wide to me, so we're going down the wide complex pathway. The other thing is it regular or irregular? I would say it's pretty regular in terms of the intervals and in terms of what the QRS complexes themselves look like. So it's wide complex, it's more of a regular. It's pretty high amplitude. It's not kind of just like puttering along like we had said before when we mentioned VFib. So that gives us a little bit more of a differential. And so what we're really seeing here is a classic example of ventricular tachycardia. All the QRS complexes are going in the same direction. They're wide, they're fairly similar in shape and morphology, and so this is a very classic example of VTAC. A VFib type of picture will be much more fine. It's not going to be quite as large amplitude and pronounced as this.
Okay, so next one here. So this one, again, there are a couple of classic findings that I see when I look at this right away. The first thing I'll say is we're looking at the rate, right? So it's going a little bit faster. If we look at the actual spacing, so again, we're looking the normal rates. We use that 300, 150, 100 rule, or you can just count the full rhythm strip, multiply by 6 because they're normally 10 seconds long. Using either of those tricks, this is fast. Excuse me. And then the next thing you're looking for, again, we did rate, now we're looking at rhythm. Well, so first I'll look at is it narrow or is it wide? Because I'm in the tachycardia bucket. And I'm looking at this, and these are largely narrow complex. There are a couple of them I'm like, oh, this looks a little bit unusual in terms of the morphology of the QRS, but they're less than 120. They're a narrow complex tachycardia. And then I'm looking at these P waves, and then I'm seeing a lot of things that look like P waves, and more specifically, I'm seeing a pattern. I'm seeing a 3 to 1, 3 to 1, 3 to 1. And so when I look at that, that is more specific to me. Whenever I see some sort of consistent pattern, that's telling me it's flutter. And so a lot of you correctly identified that we're looking at flutter here, and specifically a 3 to 1 penetration pattern of the flutter, because again, you have an atrial tachycardia, you have P's before every QRS, but you don't have QRS after every P because of the fact that you're having a 3 to 1 ratio. And so this is sort of the classic picture, that sawtooth for atrial flutter.
Okay, guys, what do you think is going on here? Give us some answers. Take a good look. This is a little bit of a trickier one again. We notice it's going pretty slow, so let's kind of start thinking about going down maybe our bradycardia pathway. Yep, some people are saying bradycardia. That's right, okay. Let's try to identify, remember, look at our P's, look at our QRS's. Is there a P directly before every single QRS? Are there any dropped beats? Those sort of things will help us out. If we kind of look, we do see what looks like, at least over here, we've probably got a dropped beat. And so we right away know it's probably not a first degree heart block. It doesn't really look like the P. There are some P's that maybe look like they're in front of the QRS's, but it certainly doesn't look like there's a constant PR if that were to be the case. So that would throw out a Mobitz 1. Let's see, does it look like there's a P before every QRS that's getting longer until we get a dropped beat? Well, not really, because here's a P, then there's another P here, then we have a PR, maybe if we call this a PR, or just a P that happens to be in front of this QRS here. Then we've got another one here and here. Oh, now we have a random key. So let's march it out. Deciding between Mobitz 2 and complete heart block can be tricky. So let's kind of march it out and see if the intervals appear to be more constant. So we can really kind of march these P's a little bit more along here. They really march out evenly well. And honestly, our intervals look pretty even for the most part as well. So this is a much more classic example, again, of third degree heart block. Where there's complete disassociation. Again, can get a little tricky because sometimes it does look like there's a P before every QRS. So if you only looked at the first half of the rhythm strip, I could see how you would be very confused and think that maybe this was a Mobitz 2. But especially if you look down here, you see dropped beats, you see that really, like, look at this one, there's not really any correlation between the P's and the QRS's, and you're getting P's that are really classically marching out very evenly with themselves, and RRs that are really marching out. So that's kind of what you see very classically with this third degree heart block. take a look at this EKG. Sorry, it's a little bit dark. I was kind of taking this from a book where I could find the best example. But take a look here and see if you notice anything particular standing out. We're going to just go through 2 EKGs here briefly before we have to wrap up on some of our time. So take a look here, see if there's anything you notice that's going on, what your differential is. Feel free to type in your answers in the chat box here. And then and we'll talk about it a little bit. In the meantime, if you have any more questions about anything else, shoot us a question in the Q&A box, and we can always get a hold of those as well. I see a couple of answers coming in. Some of them are kind of right. Like I see people seeing ST elevation. I see someone saying a STEMI. Ooh, this is a really good differential to think about. They said anterior leads. Interesting. Yeah, I do see some elevation. Remember, when you're looking at an EKG, look up, look down, look all around, look at every lead. And there's something very classic that we notice about this EKG and how the elevation is very diffuse. It's actually not just in a specific distribution. Probably even more importantly, we don't see reciprocal changes. We don't really see a lot of depressions anywhere. And so this is very classic, which you can see pericarditis. And the kind of buzzwords here are diffuse ST elevation, and I'm actually pointing out those with the white arrows here. You see lots of slight little elevation throughout many, many leads. Almost every, maybe V1 doesn't have it quite as much, but honestly, almost every other lead has a little bit of elevation. Not kind of a crazy amount, but just small amounts of elevation, which you see in pericarditis. The other classic pericarditis type of finding is PR depression, and that's what this red arrow is pointing to. It's a little trickier to see, but you can definitely see it here in leads 2. I think V3 has a really good example of the PR depression. You really would expect to see PR depression in every lead except AVR. Actually, you might even see a little elevation. So AVR, you do not see that. But on all the other leads, the classic findings are kind of just this diffuse ST elevation with some PR depression. But it is very important to distinguish this from other types of ST elevation, because this would be detrimental if you put this person in the cath lab for a heart attack for a STEMI. So keep in mind that there is this is more of the pericarditis picture. Someone's asking to describe lead 3. I don't see honestly a lot of elevation there or PR depression. You're not necessarily going to see the pericarditis findings in every lead. It's just that you're going to see most of it. You see kind of small diffuse ST elevation through most of the leads, and we don't see any reciprocal changes. We don't see any elevation that will be isolated just to a particular pattern of a heart, and we don't see any of those reciprocal changes that would lead us to think that it's a STEMI.
Awesome. We also just got another question, so we'll take a break in between and answer this one. So this is a great question. How to know which antiarrhythmic to use for which type of condition. So I will preface this by saying I'm not a cardiologist, and so most of these questions will in real life be answered by the cardiologists. They generally dictate what makes the most sense in terms of nodal blockade, not nodal blockade, chemical, electrical cardioversion. There are a lot of considerations. I will say there are certain conditions, such as Wolff-Parkinson-White, where one classic sort of medication that you should know for step 1 is to treat with procainamide. So that's a very typical thing. And then another thing we talked about with Wolff-Parkinson-White is to not use those nodal blockade agents. Another thing to be aware of is the class B antiarrhythmics. Those ones are better for people with structural heart disease. The class C ones are contraindicated in patients with structural heart disease. These are sort of broader rules. I would never say like you definitely have to use amio for this type of patient. That's something I'd leave to cardiology. But there are some broad classes of contraindications or preferred uses, which might be helpful to know. And most of those I think are mentioned explicitly. The ones that I would expect you to need to know for your exams are listed pretty explicitly in first aid in terms of the different contraindications or preferred settings. But generally that is a question I leave for EP. But Justine, what's your experience been with that?
Yeah, completely agree. It's very tricky. And this is something that even in the ER, when we have patients come in, if it's a funky arrhythmia or I'm considering starting on a patient on an antiarrhythmic, especially if they're going to be going home or I have any concerns about it, we're always running this by our cardiology friends to get better advice. The pretty much as you had mentioned, which is, yeah, I agree completely. The real big thing to know for the purposes of STEP is WPW. If they ask you what to treat it with, there's 2 answers. It's either propranolol or you're shocking them. Those are really the only options. So everything else you really have to worry about it. Like amiodarone is a no-no. You know, the calcium channel blockers, the beta blockers. The only drug that you really could be giving them safely would be propranolol, or you would cardiovert them. So that's honestly probably really the only classic one I can think of off the top of my head for step.
Yeah, absolutely.
Let's see. We have one more case here I think that we can fit in before we wrap up. Definitely shoot us your questions and hopefully we can get to, you know, everything you need. But this is one more that's very classic. If you have any ideas of what's going on in this EKG, I see someone already said the answer, or starting to send some things in. Someone said restrictive cardiomyopathy. That's very close. Not exactly what's going on here. Let me give you a little clinical background too on this patient. Let's say that they come in because they had a stab wound to the chest as a trauma patient, and they are hypotensive. They have jugular venous distension in their neck. Their veins are just bulging out, and you really can't hear their heart sounds very well. You get an EKG like this because they're, you know, complaining of really sharp chest pain and feel like they can't breathe. So what's going on here? I see a lot of people already saying it. This is cardiac tamponade. And you see the classical electrical, and someone said back triad, that's great, but classical electrical alternans on the EKG. And in particular, you see the arrows down here where it's the QRS complexes are changing in amplitude, high, low, high, low. They're alternating back and forth, and that corresponds to basically the heart swinging back and forth in its pericardial sac, which is where you get those changes there. And so in real life, you actually classically with the fusions and things like that, you just see low voltage throughout. But the one that they love to test on it, if they're going to test you on it for the purposes of the STAP exams, you're going to see this type of picture where it's an electrical alternans, usually in a trauma patient or someone with cancer, and they're in tamponade. And they'll usually give you a clinical picture that's going to correspond with that.
I think that covers most of the content that we had for today. As always, if you have any additional specific questions, feel free to reach out. We'll throw back that slide about our info, our contact information.
Thanks so much for joining us tonight, everyone. We appreciate you coming out. Have a great night.